This week's module will cover chemical messengers known as neurotransmitters. There are two groups of neurotransmitters, small and large. The small molecule are rapidly acting. They are produced in the axon terminal itself and recycled there. And they cause an acute response of the subsequent or receiving neuron. The other one is a large molecule, very slow acting neurotransmitter, and they are produced in the neuron cell body and must be transported to the axon terminal via exoplasmic transport anterograde. And these large molecules will cause a prolonged response in the receiving neuron. There's several classes of small molecule neurotransmitters, and we're just going to cover 4. Class 1 is acetylcholine. Class 2 are the amines, which are norepinephrine, epinephrine, dopamine, serotonin, and histamine. Class 3 are amino acid neurotransmitters, and that includes gamma aminobutyric acid, also known as GABA, glycine, glutamate, and aspartate. And then class 4 are gases, and we're only going to talk about nitric oxide as the gas in this lecture. The large molecule neurotransmitters are also known as neuropeptides, and in this class we have endorphins or enkephalins, which are the opioids involved in suppressing pain signals, substance P, somatostatin, choleocytokinin, an antidiuretic hormone also known as vasopressin. We're really only going to cover endorphins and substance P in this course because somatostatin, choleocytokinin, and ADH are also hormones, and we'll cover that information about those chemical messengers in the endocrine system. Neuromodulators are chemicals that have no direct effect, but they can modify the effects of a neurotransmitter, such as they can mimic it, enhance it, or inhibit it. A lot of drugs can act as neurotransmitters. For example, I show here the cocaine plant, and the cocaine plant can enhance the effect of norepinephrine or even mimic the effect of norepinephrine. And we'll talk about some that have the inhibitory effects as well. Agonists versus antagonists. So neuromodulators have an agonist or an antagonist effect on the neurotransmitter. If you look at this diagram, the first one on the left is just showing some neurotransmitters that kind of look like elongated oval vitamin pills to me, and I've got the yellow letters NNT in them, and that's just a regular neurotransmitter, and it's showing that it's fitting perfectly in a receptor made just for that neurotransmitter. Then in the middle diagram, it is diagramming an agonist drug. So the agonist drug in this diagram is showing that it mimics or has the same exact effect as the neurotransmitter. Then in the third drawing that's on the far right, it shows the neurotransmitter being inhibited or preventing from binding with its receptor by an antagonist type drug that's blocking it. So those are the 3 examples. Agonists will enhance or mimic. Antagonists will interfere or prevent. So just a little more detail on agonists and antagonists because they can have direct effects and indirect effects. So an direct agonist effects are substances that bind to a receptor and can cause the exact same effect as the neurotransmitter, or you can say it mimics the neurotransmitter. Indirect agonists will stop the reuptake of the neurotransmitter and or increase the production of the neurotransmitter. So when it stops the reuptake, it allows that neurotransmitter to be in the synaptic cleft longer, enhancing it or prolonging that neurotransmitter's effect. An antagonist, its direct effect of an antagonist is substances that completely prevent the neurotransmitter from binding to its receptor. It blocks it, like we saw in the diagram on the previous slide. The indirect antagonist will interfere with the production typically stop it or slow it down, and it can interfere with the release of the neurotransmitter. There are two types of neurotransmitter receptors, ionotropic and metabotrophic. Ionotropic receptors are ligand-gated, and typically ligand-gated channels, and they will allow the passage of ions when activated. They mostly allow the movement of sodium or potassium or chloride to go through them. Yes, a little bit of calcium can go through these as well, but not so much as sodium and potassium and chloride. Metabotropic receptors are G protein coupled receptors, and they are used pretty much exclusively with the second messenger system. I'll talk a little bit about the second messenger system here in this lecture. We will cover it in detail in endocrine, so I just kind of brief over it. So don't worry about understanding every detail of the second messenger system in this lecture, because we will cover it in detail in endocrine. So the metabotropic receptors, the main effect they have on the receiving neuron, or whatever neuron is being stimulated by the neurotransmitter that binds with it, is to increase calcium inside the cell or inside the neuron, which will activate a kinase enzyme which stimulates protein synthesis. So these receptors, these metabotropic receptors, are the main ones that are involved with long-term potentiation and neuroplasticity. Acetylcholine. I know you're familiar with this neurotransmitter, but I'm going to just give you a few more details. It is categorized as one of the small molecule neurotransmitters, so that means it is synthesized in the axon terminal. It requires acetyltransferase to complete the process by combining acetyl-CoA plus choline. It is broken down in the synapse into acetate and choline by acetylcholine esterase. And the presynaptic terminal will recapture the released choline and use it to recycle or make more neurotransmitters. It is mostly stimulatory, but it can be inhibitory depending on the type of receptor that it binds to. Cholinergic neurons. All neurons that produce and release acetylcholine are cholinergic neurons. In this diagram, it demonstrates that all neurons, or all preganglionic neurons of the autonomic nervous system, both sympathetic and parasympathetic, are cholinergic neurons. And all postganglionic parasympathetic neurons of the parasympathetic nervous system are also cholinergic neurons. And only one neuron in the sympathetic nervous system that goes to sweat glands is also a cholinergic neuron. There are two types of cholinergic receptors, and one of them are nicotinic receptors. They are named for the agonist nicotine that stimulates them. They are ionotropic, which means they are ligand-gated ion channels. And when acetylcholine stimulates them, it is always stimulatory when acetylcholine binds with them. They're located on all sympathetic and parasympathetic preganglionic neurons, their cell bodies and their dendrites, and in the central nervous system. The adrenomedulla hormone-producing chromaffin cells also have nicotinic receptors, as well as the sarcolemma of skeletal muscles at the neuromuscular junction. Other antagonists of nicotinic receptors are curare, which is a type of dart poison, snake toxins, methadone, which is a step-down drug treatment, dextromethorphan, which is a antihistamine type of drug that's put in a lot of over-the-counter cold medicines. And there's more than that, but that's all we need to know for right now. The other type of cholinergic receptor are muscarinic receptors, and they are named for the agonist muscarine, which is a mushroom poison that they respond to. Acetylcholine can be stimulatory or inhibitory depending on the subclass of these receptors. The example can be inhibitory on cardiac muscle through the vagus nerve, or stimulatory on smooth muscle in the gastrointestinal tract. These muscarinic cholinergic receptors are located on all target organs stimulated by the parasympathetic, postganglionic cholinergic neurons, and eccrine sweat glands stimulated by the sympathetic postganglionic cholinergic neurons. Other antagonists of muscarinic receptors are atropine, which just specifically blocks sympathetic nervous system signals, and then belladonna, also known as nightshade, and scopolamine, which is a antiemetic for nausea and dizziness, and it blocks parasympathetic nervous system neurons. There are several drugs that can affect acetylcholine, and they can act as agonists and antagonists. I'm not going to read all of these, and you're not expected to know all of these. I have it bolded, the two main ones you're supposed to know, and I'll list the main ones you need to know. You need to know that nicotine and muscarine are main agonists. Also, sarin gas is, and Alzheimer's medications such as Aricept or Exelon. Antagonists, ones that affect acetylcholine that block or decrease its effects, are antihistamine, such as over-the-counter ones, Benadryl, NyQuil, Dimetapp, and all pain relievers that have a PM with it, tricyclic antidepressants, such as Elavil, or muscle relaxers, such as Flexeril, and also antiemetics, such as Dramamine or scopolamine. And some anti-Parkinson drugs, such as benzotropine, will also act as antagonists. And toxins, such as botulism and Botox. I already mentioned atropine earlier, and then Carrere, the dart poison. Now we're moving on to glutamate. Glutamate is the main excitatory neurotransmitter in the central nervous system. It is synthesized in the axon terminal, and there's two pathways that it can be synthesized, either through the Krebs cycle via alpha ketoglutarate acid turning into glutamate, or glutamine turning into glutamate. The glutamine to glutamate pathway requires the assistance of nearby astrocytes. You should recall from our topic on nerve tissue that astrocytes surround synapses. Well, in addition to quickly taking up potassium in the synapse, astrocytes will also take up neurotransmitters. In this diagram, it's specifically taken up glutamate. The astrocytes will then convert the glutamate into glutamine and pump it out of the cell into the nearby axon terminal. That axon terminal will take up the glutamine and then convert it into glutamate. So you have this nice recycling process through the assistance of astrocytes surrounding the synapse. Glutamate has several receptors. It's got ionotropic receptors that I'm just going to use the initials, AMPA, and then kainate, and then NMDA. Those are the ionotropic ones. And it has just one metabotropic G protein-coupled receptor. If you look at the diagram, the metabotropic ones, I don't know if you can see it very clearly, but it's a 7-membrane transmembrane protein that weaves in and out. We covered those a little bit when we did membrane transport at the very beginning of the quarter. And then the ionotropic ones will be ligand gated. That'll allow the ions to pass through. The AMPA and kainate ionotropic receptors are widely distributed throughout the entire central nervous system. You'll find them on glia cells, the hippocampus, the amygdala, on basal ganglia, and throughout the cortex. They primarily permit the influx of sodium and efflux of potassium. These ionotropic receptors of glutamate, AMPA and kainate, are responsible for mediating fast EPSPs, excitatory postsynaptic potentials. NMDA ionotropic receptors are a little bit different. They're only found on neurons in high concentration, and they're in very high concentration in the hippocampus, but they're only found on all neurons in the CNS. They require 2 neurotransmitters to activate. One is glutamate, and the other is glycine. It has to have both of them to open it. It allows an influx of calcium in addition to sodium and then efflux of potassium. But its main function is to allow a lot of calcium into the cell. NMDA philosophy is a little different than any other of the transport proteins we have talked about before. When it's at rest, where it's considered polarized or hyperpolarized, it has a molecule of magnesium blocking the channel, so nothing can get in or get out. No ions can pass. So when the membrane is depolarized, it will dislodge that magnesium out of the NMDA channel, and then cations can flow through, specifically sodium and calcium entering in and potassium flowing out. The G protein metatropic receptor of glutamate will utilize the second messenger system of activation. This example is of the phospholipase C example. What happens is when glutamate binds with that 7-membrane transmembrane protein that you see on the left, it's kind of a gray and it goes in and out of the membrane. When glutamate binds to that, it activates the G protein that's attached to it. When G protein is activated, it gets phosphorylated and it'll change a GTP for GDP. It'll separate from its triune complex so that the G protein, just linked to the alpha portion, will move along the membrane. So it's going to move along the membrane, in this example, from the 7-membrane protein channel to the right, and its goal is to connect with a specific enzyme called phospholipase C. And when it binds with that phospholipase C enzyme, it'll cause a specific phospholipid to split in two. And when that causes that phospholipid to split in two, it creates two other molecules that are second messengers. One is called DAG, D-A-G, and the other one is IP3. The DAG second messenger will activate protein kinase within the target cell, and that'll stimulate protein synthesis. The IP3 will release intracellular calcium into the cell, and that will also increase protein synthesis. Now on this slide, I'm going to try to explain how glutamate affects long-term potentiation. All the words I'm going to say are on the following slide, so I'll just skip the following slide. So looking at the diagram, you see where I have a purple arrow on the sending axon, which is on the left side of the diagram. And it's representing an action potential coming down that neuron. And we all know that once the action potential reaches the axon terminal, it'll open voltage-gated calcium channels, allowing the calcium in, which will go through all this crazy vesicular cycle and release the neurotransmitter. So after it has released the neurotransmitter, in this case it's glutamate, the glutamate will go across the synaptic cleft via kinetic energy, and it's going to bind with these AMPA receptors and with the NMD receptor, which I colored in purple. So you'll see if you're going from the bottom up, on the receiving dendritic spine, you've got two lightly green protein channels, and they're representing the AMPA protein channels. Then the colored purple one, and that's representing the NMDA channel. And then the one on the far end that to me looks like a choo-choo train with a bunch of dynamite attached to it, that's supposed to represent a metabotropic G protein coupled receptor. So the glutamate's going to bind with all those receptors that you see on the receiving dendritic spine postsynaptic membrane. So when it binds to the AMPA and they open up and allow a lot of sodium in, it's going to cause depolarization of at least the postsynaptic membrane. It may not be enough to facilitate an entire action potential of the receiving neuron, but we already talked about how this glutamate can, with these receptors, can elicit fast EPSPs. So once that membrane is depolarized, that will dislodge that magnesium ion that is blocking the channel of the MDA channel that I have colored in purple. You can see that magnesium is kind of a oval shaped orange thing that's blocking the channel. So it's the action of the AMPA receptors are necessary to facilitate the opening of the NMDA receptors, to allow the calcium in. So now you're going to have and remember that these NMDA receptors require glycine as well. And I see I have a glycine right there. So it needs to have the glycine bind with it, the glutamate. Once the membrane has depolarized, it doesn't have to be strong enough so that it elicits an action potential, but depolarized enough so that it dislodges the magnesium, sodium, and calcium will flood in. When calcium floods into the dendritic spine, it will bind with calmodulin, and when it binds with calmodulin, that complex will activate protein kinases. The protein kinases will stimulate protein synthesis to make more AMPA receptors. So it'll make more of those and put them in the membrane. So the next time the sending axon has a action potential come down and releasing the glutamate, there will be more AMPA receptors within the receiving neuron's membrane for the glutamate to bind with, to open up, to allow more sodium in. So this whole process is increasing the efficiency of the receiving neuron. Now, when the metabotropic membrane is activated, it's going to release intracellular calcium. The DAG will also stimulate protein kinase, and the intracellular calcium that's going to be released from the endoplasmic reticulum within the dendritic spine will also bind with calmodulin. So the big picture is this is all causing protein synthesis. So when you have protein synthesis, you're going to have a whole bunch of more ion channels being produced, and that dendritic spine is going to get bigger and bigger every time if there is sequential or tentonic rapid firing of action potentials. Once you get to a certain level, then the neuron, the receiving dendritic spine, will start to produce nitric oxide neurotransmitter. That's what that NO means underneath the word that says retrograde messenger. It doesn't mean no, like no, it's not going to happen. It stands for nitric oxide. The nitric oxide will diffuse right out of the dendritic spine and then go and diffuse into the axon terminal of the sending axon. That nitric oxide will actually enhance the release of more glutamate. So then you have this nice cycle going. So this is the biggest part of long-term potentiation and neuroplasticity. It happens, we mentioned before, it happens with acetylcholine, and we're just going to use glutamate in this example, where the glutamate neurotransmitter is going to facilitate protein synthesis in the receiving dendritic spine, and that dendritic spine will grow in size and may produce or bud off additional dendritic spines if it receives a lot of rapid fire action potentials. I already said all that, so we're moving on. I could only find one drug that was a glutamate agonist. I'm sure there are more, but the drug I found was D-cyclosporin, which is an immunosuppressant type drug used for organ transplant individuals, so they would not reject the new tissue. I was able to find several glutamate antagonists. I'm just going to name a few here. One is phencyclidine, also known as PCP or angel dust, and it specifically targets NMDA receptors. It blocks them, so it has a profound effect on not being able to learn or have long-term potentiation or neuroplasticity. Another drug that blocks or inhibits or acts like an antagonist to glutamate is ketamine. The ketamine is used for anesthetic surgery, but it's also become a popular date rape drug, and it's also known as Special K. A few more glutamate antagonists is memantine. I'm sorry, I'm sure I'm not pronouncing that correctly. It's an Alzheimer's drug, and it's used to reduce the amount of glutamate in the interstitial fluid, so it helps to get it out of the synapse rather quickly, because too much glutamate actually can lead to cell death, overstimulation. Then you have dextromethorphan. We talked about also that with acetylcholine, and it is found in a lot of cold and cough medicines over the counter. Another popular drug is tramadol. It's a synthetic opiate, and it's used for pain management, and anti-epileptic drugs. All of these will act as glutamate antagonists, either blocking a receptor or inhibiting its release or reuptake. Nitric oxide is a gas neurotransmitter, and it'll diffuse right through the phospholipid membranes of the neuron that produces it. So it's not stored, but it is synthesized on demand. The synthesis may be triggered by activation of NMDA receptors, because we talked about its role in neuroplasticity in the previous slides there. It is secreted by the neurons involved with long-term behavior or long-term memory, and it plays a significant role in long-term potentiation by retrograde stimulation of the axon terminal to release additional neurotransmitters. Now we're moving on to amine neurotransmitters, which include norepinephrine, epinephrine, dopamine, serotonin, and histamine. Catecholamines are both neurotransmitters and hormones. They are synthesized from tyrosine. The neurotransmitters are synthesized in the axon terminal, and the hormones are synthesized by chromaffin cells in the adrenal medulla gland. They are broken down by monoamine oxidase, or MAOs. Monoamine oxidase inhibitors are drugs that block the MAOs, so they will act as the catecholamines agonists, enhancing the effect of the neurotransmitter/hormone. These are antidepressants. They used to be prescribed widely when they were first discovered because they were very effective at improving the person's psychological well-being and improve their mood. However, they're pretty deadly if taken with the wrong kinds of food, and it was actually very difficult to manage their patient's diet. If it's taken with the wrong drugs or food, it can cause deadly high blood pressure, particularly if taken with alcohol. So they're not prescribed as much as they used to be, but they're still around. So it's important to know that I've actually had patients in my practice over the years that were taking some MAOIs. Synthesis and reuptake of norepinephrine at a synapse. Synthesis occurs inside the vesicle in the axon terminal. It'll take dopamine, get it trapped inside the vesicle through a transport protein called a VMAT, vesicular monoamine transporter, and it'll then inside the vesicle convert dopamine into beta hydroxylase and eventually norepinephrine. It's also retaken up or taken back up again out of the synapse back into the axon terminal. It's removed from the synapse through the synaptic cleft via presynaptic norepinephrine transporters, or NETs, NETs. These NETs, these reuptake transporters, are inhibited by cocaine and tricyclic antidepressants. Synthesis of epinephrine at the synapse. This occurs in the cytoplasm of some CNS neurons. What happens is the norepinephrine that was formed inside the vesicle from dopamine will leave the vesicle and enter the cytoplasm. Then norepinephrine combines with phenyl something I can't pronounce will become epinephrine in the cytoplasm. Adrenergic neurons. Adrenergic neurons secrete norepinephrine or epinephrine. And just to remind you, norepinephrine is the primary neurotransmitter for the sympathetic nervous system. Norepinephrine will bind with adrenergic receptors, and it is considered the feel-good hormone. That's why there's many drugs that will act as agonists to enhance its effects. There's types of adrenergic receptors. There's 4 of them, and all 4 are metabotropic G protein coupled receptors. You have 2 alpha receptors, which have a strong affinity for norepinephrine, and then you have 2 beta receptors that have a strong affinity for epinephrine. The alpha receptors are located on blood vessels and in the brain, and the beta receptors are located on the heart, bronchioles, the brain as well, and skeletal muscle. You've probably heard of people taking beta blockers for tachycardia or to reduce their heart rate. Norepinephrine and epinephrine agonists and antagonists. Well, the agonists are tricyclic antidepressants, and they block the reuptake of norepinephrine and actually all catecholamines. It's also one of the popular ones is amitriptyline. Also, cocaine will block the reuptake. Amphetamines and ephedrine will increase released stored epinephrine. So inside the neurons, they store up norepinephrine, and this amphetamines will release it. So the body gets a dumping of norepinephrine. Monoamine oxidase inhibitors, the antidepressants I spoke about earlier that break down the catecholamines, but they don't prescribe them as much because it's too dangerous if they don't have a strict diet, and if they eat the wrong food or drink the wrong stuff with taking this drug, it can lead to death. Then you have antagonists that are drugs that block the receptors. Alpha blockers are blocked for treatment of PTSD, and beta blockers are used to block receptors to treat tachycardia or increased heart rate. Norepinephrine and epinephrine in the synapse is really quick. It's released, and then within 2 to 3 seconds, it's completely recycled. Now we're moving on to dopamine. There's 2 neurological pathways of dopamine in the brain. You have the nigrostriatal pathway, which is motor control. And then you have the mesocortical pathway, which is the reward center. And just as a side note, overstimulation of D2 receptors, which is there's 5 dopamine receptors. If you have overstimulation of the D2 receptors with dopamine, it can lead to schizophrenia. The hypothalamus can release dopamine, and it actually acts as an inhibitor to prolactin. Dopamine is broken down by monoamine oxidase, the MAOs. I already mentioned that there's 5 metatropic receptors for dopamine, and it too is a feel-good hormone. Agonists and antagonists of dopamine the agonists are amphetamines, cocaine, crystal meth, because they block reuptake. LSD will stimulate the D2 receptors, and if it's overstimulated, it's going to lead to schizophrenia. Levodopa promotes synthesis, and it's used to treat Parkinson's disease, so that those individuals with Parkinson's who have reduced dopamine will be able to produce some. And then monoamine inhibitor antidepressants, they will block the breakdown. Again, I want to reiterate that they're dangerous. For the wrong kind of diet leads to death. Antagonists are the whole grouping of antipsychotic drugs. Now we're moving on to serotonin. It's an amine, but it's not a catecholamine. It's also known as 5-hydroxytryptamine, 5-HT. It's synthesized from tryptophan, so you get it from drinking milk and eating turkey. Tryptophan will lead to the 5-hydroxytryptophan, then it goes into the 5-hydroxytryptamine, and then it leads to serotonin. So basically, I really don't care about the steps in between. Just tryptophan makes serotonin. And that is broken down by MAOs inside the neuron or in nearby glia. Serotonin has 5 receptors. The receptors are, almost all of them are metabotropic except for one, and that is the 5-HT3. It's ionotropic. Serotonin has these specific receptors that will uptake the serotonin. So the neurons are big recyclers of serotonin. And these receptors are the serotonin transport proteins, are known as also as SERT, S-E-R-T. And I'm stressing that because there's a lot of medications that prevent the reuptake, and most antidepressive or anti-anxiety drugs now are working on these receptors, preventing reuptake, keeping the serotonin in the synapse longer, as opposed to using the dangerous MAOs, MAOIs any longer. Serotonin agonist and antagonist. Agonist is LSD, peyote, ecstasy, a lot of the narcotics, a lot of the psychotropic narcotics. And then we have the selective serotonin reuptake inhibitors, such as Prozac and Zoloft. You will have patients that are taking Prozac and Zoloft, and they're going to block that reuptake. And still, MAOIs are an agonist because they will prevent it from breaking down in the synapse. Then you have the antagonists that are drugs that prevent nausea and vomiting, and they are typically prescribed to individuals going under cancer therapy, such as chemotherapy or radiation. Some of the functions of serotonin. Serotonin has so many functions. We're going to talk about serotonin and endocrine as well. So I'm just going to touch on a few, but it is just a broad neurotransmitter, and also it is a hormone too. It increases happiness, decreases anxiety, increases satiety, it regulates bowel function, improves sleep, improves mood, regulates temperature, decreases pain. And when we get into our pain and temperature, we'll talk how serotonin plays a role in releasing the endorphins and enkephalins that are natural opiates to help reduce pain. A deficiency can lead to depression and schizophrenia. The thing about serotonin, though, is too much can also lead to depression, and too little will lead to depression. So this is one of the cases where our body just needs to have an absolute balance of it. Serotonin, the majority of serotonin in the body is actually found in the intestinal system, and some found in the brainstem. But mainly it's in the intestinal system, which is interesting because it helps move our food along and helps us with digestion and absorption of nutrients. And the way I think about it is, with an increase in satiety, it also helps you to enjoy your food and feel that what you have eaten has been satisfactory. So we're going to move on now to histamine. Histamine is an amine, but it's not a catecholamine. Its cell bodies are found in the hypothalamus, and the axons from the hypothalamus will project to all parts of the brain and the spinal cord. It has 4 metabotropic receptors. Histamine is also produced in mast cells and basophils in response to different kinds of invasion of microorganisms, particularly if it's a virus that is responding to, or a allergen. Histamine can be ingested. It is built up and stored in fish. Just as a side note, if you go to a fish market or you go past the case in a grocery store to get fish, if it smells fishy, it's bad. Fish should only smell like the water it came out of. It should not have a stinky fish smell. If it has a stinky fish smell, it's no good. Don't buy it. So, sacombrotoxin is a fish poison. And you ingest that fish poison. If fish has been left around for too long, it builds up this poison. It is ranked among the top 4 most reported seafood-borne illnesses. And I have here the FDA link if you want to go to that to find out more about this toxin and how to avoid it. But the most common culprit is tunas and mackerel, and that's fresh tunas and fresh mackerel. But again, if you have tuna, if you get it in a restaurant, it should not smell fishy. And that's just my best advice for avoiding this, ingesting histamine. Agonists and antagonists of histamine. The agonists are opiates. They stimulate the mast cells to release the histamines. And bethahistine, which is an anti-vertigo drug prescribed for Meniere's disease. We'll cover Meniere's disease in neuropathophysiology towards the end of the quarter. And Meniere's disease has to do with the labyrinth in the inner ear getting filled up with too much endolymph, so this drug helps to improve that circulation. Antagonists, we all know what antagonists of histamine are. They're antihistamines, such as Benadryl. And it also works with acids like in Tums to help suppress or reduce the effect of histamines. Histamines function as an inflammation. When an organism breaches the skin or causes an irritation within the body, the nearby tissues will release these chemicals, specifically substance P and bradykinin, and that'll signal the release of histamine. Histamine will cause the nearby blood vessels to dilate to get more blood, particularly white blood cells, to the injured area so that neutrophils can respond. They're the first responders and phagocytize, and then eventually macrophages so that the immune system can do its job. Well, the way histamine does that, it causes vasodilation. Well, vasodilation decreases blood pressure because it decreases peripheral resistance. Then you have the peripheral resistance decrease, but the heart is going to feel the need because of the sudden pressure drop to increase its rate to get the amount of blood to the tissue that it needs to. So it'll cause the heart to work a little bit harder. It initiates the pain and itch response. It increases stomach acids. And I didn't mention here, but it also increases mucus production. And part of that mucus production is what we experience when you have a head cold, and that's why so many over-the-counter cold flu-like medications have antihistamines in it to reduce this decrease in mucus production symptom. Glycine is an amino acid neurotransmitter, and it's synthesized from the amino acid serine. It has excitatory and inhibitory effects in the central nervous system. Its only excitatory effect in the brain is when it's combined with glutamate, when it binds to an NMDA receptor. Remember, the NMDA receptor is the one that has the magnesium lodged in it, and it's the only one that, when activated enough, it's part of long-term potentiation. So glycine has a role in learning and memory. It's inhibitory in the brainstem and spinal cord when it binds to glycine R, chlorine receptors. Because remember, inhibitory neurotransmitters cause the inside of the cell to become more negative. So if it binds to chlorine receptors, which has a negative charge, and it allows an influx of chlorine, it'll make it more negative on the inside. It is the most common inhibitory neurotransmitter in the spinal cord. Not in the brain, but in the spinal cord. It has 2 receptors. Already talked about those a little bit already about them. They're both ionotropic, which is NMDA receptors, and glycine R receptors. The glycine agonists and antagonists are: agonist is alanine and taurine amino acids. I have a picture of roast beef in a energy drink, Red Bull. That's because alanine is found in high quantities in red meat, so that's a roast beef sandwich. And taurine is found is actually supplemented in a lot of these energy drinks that are very popular now. The antagonist is strychnine and caffeine. So strychnine and caffeine will prevent the glycine. So they'll prevent it from binding to these NMDA receptors. They will prevent any kind of inhibitory effect. So strychnine and caffeine will cause overstimulation. And it can be quite serious and deadly with the strychnine. Now we're going on to gamma aminobutyric acid, also known as GABA, G-A-B-A. It is an amino acid neurotransmitter, and it is the main inhibitory neurotransmitter in the brain. So before I said glycine is the main one in the spinal cord, but GABA is the main one in the brain, inhibitory. It affects both pre- and post-synaptic neurons, interestingly enough. Presynaptic membranes have GABA transporters on it. They can reuptake the neurotransmitters from the synaptic cleft. So in the presynaptic one, it'll inhibit the reuptakes, and then on the postsynaptic one, it'll inhibit it'll cause inhibitory effects of the receiving receptors on the postsynaptic membrane. GABA is taken up by the surrounding astrocytes, just like glutamate was. The astrocytes will convert the GABA into glutamate and then into glutamine. So they have very similar processes. The astrocytes will pump that glutamine out of its cell, and then the axon terminal will take it in, and that'll convert that glutamine into glutamate and then glutamate into GABA at the axon terminal. I find it interesting that the primary stimulatory neurotransmitter is a precursor to the primary inhibitory neurotransmitter in the brain. GABA receptors, you've got 3 of them. 2 are ionotropic, GABA A and GABA C, and they open chlorine channels and allow influx of chlorine, which is going to make it more negative on the inside, mediating a fast IPSP, inhibitory postsynaptic potential. The metabotropic one is the GABA B, and they're linked to a G protein, and they're going to inhibit calcium influx. Remember, that's what the metabotropic G protein receptors do. They increase, if they're stimulated, they increase intracellular calcium, but if they're inhibited, they're going to decrease intracellular calcium. GABA agonists and antagonists. The agonists are alcohol, barbiturates, which are sedatives or anticonvulsants, benzodiazepines, which are anti-anxiety drugs. All of these will bind with receptors and mimic the same effects as the inhibitory GABA neurotransmitter. The agonists are stimulants and convulsants, which will prevent the binding of the GABA and prevent the inhibitory effects. Primary functions of GABA is to slow you down, to relax you, to increase sleepiness, decrease anxiety, decrease alertness, and decrease memory of too much, and decrease muscle tension. It's pretty essential neurotransmitters for you to relax and be able to fall asleep. Opioids are next. They're neuropeptides, meaning they're pretty large, and they are produced in the cell body and have to transport to the axon terminal via exoplasmic anterograde transport. You have enkephalins, endorphins, and dynorphins. They are produced in the hypothalamus, the pituitary gland, the adrenal medulla, the CNS neuron soma, which I just mentioned, and in the gut. The primary function of opiate neurotransmitters or neuropeptides is analgesic. Their primary function is to block the pain signals. The way they do it is they affect metabotropic G protein receptors. This is an example of the cyclic AMP second messenger system. I talked previously about the phospholipid C earlier when we were talking about glutamate, but this is a different type of second messenger system where the hormone will attach to a G protein coupled receptor, and which has a G protein attached to it. But instead of allowing the G protein to be stimulated, it will inhibit the G protein's ability to bind with an enzyme that's in the membrane called adenocyclase. If there's a stimulatory neurotransmitter in this system, like epinephrine or glucagon or adrenocorticotropic hormone as the examples, stimulating adenocyclase will cause it to convert ATP into cyclic AMP, and the cyclic AMP is the second messenger causing the target cell to undergo protein synthesis. But the opioids are going to stop that process. And so it will not allow the target cell to undergo any kind of protein synthesis or any kind of stimulation, and it won't be able to carry on the signal of pain from one point to another. Opioid agonists are morphine, heroin, fentanyl, oxycodone, oxycontin, Percocet, Vicodin. Any of these agonists, they are going to enhance the opioid response and function and reduce pain signals. Opioid antagonists are methylnaltrexone and alvemopan, and they target enteric opiate receptors, and they prevent constipation. So if patients are given morphine or some other, or fentanyl, some kind of very serious type of pain reliever or actually analgesic, and these are usually given only in extreme cases, opiates will cause constipation. So they're often given this antagonist that will just target their digestive system to prevent the constipation. Then you have methadone, which is used as a drug treatment for opioid addiction as a step-down treatment, and it'll target the CNS opiate receptors. And then you have the suboxone, which is also a drug treatment for opioid addiction, but it acts as an antagonist and an agonist. So it gives the patient both sensations to help ease their withdrawal symptoms from the addiction. And it'll also target central nervous system opiate receptors. I apologize for my fumbling in this, but some of these words I just can't pronounce, and I'm sorry. And I hope that